So we're going to try and navigate this by sharing. We're going to work on our sharing skills. So hopefully if you can't hear us, just let us know, and we're going to trade off talking. So we're going to work on our multitasking abilities. This talk, we've kind of preluded to it. It's lab matches made in heaven, or matches made in lab heaven. And we're going to talk about our learning objectives today are to first kind of talk about some functional medicine tests that we really like as naturopaths, but also to define some terms and help make everything, try to explain everything and make these terms more common use. Then we're going to talk about the functional ranges and these functional tests that would pair really well with our genetic tests based on the conditions they both treat, and how you would use both in a clinical setting to manage your patient's care. So why isn't genetic testing enough? And I think we kind of talked about this. The main thing is that genetic testing tells you about an increased risk. That is a big deal with the HLA testing. You know, that's how we usually report the answers. I mean, among other things, most of the practitioners want to know, what does this mean to my patient? What does this mean to their, their risk factor? Is it increasing their risk chance of this disease? So risk is one thing, and then functional testing is really where you're going to follow up and see whether or not this patient has this disease. And also, if they don't have it, are they going to have it in the future? So this is going to be something like routine monitoring we're going to talk about. So when and why would complementary testing be helpful? One, to see if you have it, and two, to see if to also check in to see if the patient has developed it later on in life. And there's a lot of different functional tests out there. I don't know if anybody's ever noticed that. We're going to talk about a couple of the main ones that we utilize in our practice. Organic acid testing. We're going to talk about toxic metal testing, how that can also be beneficial. And then just some of the regular functional medicine tests, and then also intracellular nutrient level testing and micronutrients. And we're going to talk about...
I don't like this page, but this is organic acids. This is what you ignore on the organic acid test. This is the computer-generated part. But when you look at the actual organic acid levels, that's the handy-dandy part that gives you so much information.
Yeah. Hormone testing. If you've used any of these regularly, these are probably, look pretty familiar to you. So just there's some natural matches between genetic testing and functional medicine testing, and they have a lot to do, or they focus or center around a lot of these conditions that we're talking about, like celiac. Like Dr. Angela was just saying, you have a patient that might have some symptoms, and you want to see if they have it, if they have it, and you're going to be testing things like tissue transglutaminase, and then there's several other, some people like zonulin and down the line. But there's also genetic testing now that and that is again going to give you an idea of whether or not they have an increased risk for celiac. So high homocysteine levels, cardiovascular disease in general, your mood, addiction, obesity, chronic fatigue, fibromyalgia, these are all conditions where they have some etiology in genetics, and also you can then use some functional testing to measure. So really what you're asking is, what's the difference between one risk allele and one risk gene and the combination here? And sometimes when you see a combination like in the vitamin D pathways, that is an even stronger need for routine serum vitamin D testing. And like I was saying too before, I wouldn't just put somebody on a supplement and check back in a year in these cases. I would want to know their genetic, their genotype, so that I could know to retest, and if that wasn't working, reassess treatment more quickly. So, anything you want to add to this for this slide?
No, I mean, and then, we can see that there's biochemical interactions when we have a combination of genetic polymorphisms as compared to just looking at one risk gene, how are these feedback loops affected, and disease associations with multiple SNPs versus one, right? We were talking about ApoE, yeah, we know Alzheimer's risk is higher with ApoE4, but now we know that MTHFR and NOS all are gonna bump up the risk. So looking at these things in combination are gonna give you a good sense of, wow, how important is it to address this right now? I mean, what's the urgency?
Yeah, should you be focusing your treatment plan on these preventative measures this early on? So there's, again, these groups that we like to kind of put together, and weight regulation is one that is, I think, incredibly important. So if you did test your patient and they were having some risk alleles here in these weight management genes, what kind of things would you start to be looking for? Well, we kind of talked about treatment strategies because of appetite control, but I was also talking about a lot of them have a huge influence on insulin resistance. So that would be sort of you would look first for the symptoms. So maybe, yes, they have the genetic genotype to be, say, overweight or diabetic, but you look at them and they look fine. They don't have any of the symptoms. They're not obese. They don't have hypoglycemia. They don't have a family history. You know, maybe there's no other symptoms that are associated with diabetes like hypertension or hormone imbalances. That would be your first cue or clue. So say they do, then you go on to the functional tests. The first one you would want to do is look at their, hemoglobin A1C. You would want to do fasting glucose and maybe even a glucose tolerance test to see how they tolerate if there is insulin resistance. That's one of the best ways to measure that. Also, leptin with SH2B2 or 2B1, you're going to see leptin resistance. So you can see that and measure leptin levels. So these are some of these tests. So treatment considerations for if you have patients with these genetic risk factors is, and this kind of summarizes what I'm just saying, monitor those blood sugar levels, monitor their insulin levels, make sure there's no prediabetes or an actual diabetes situation. You want to work on leptin resistance, decreasing leptin resistance, decreasing insulin resistance, so increasing sensitivity to both of those hormones, and measuring and monitoring their cholesterol levels. You would want to look at that because there is such an interplay between diabetes, obesity, and cardiovascular disease. And those are all functional tests, or just lab tests that you could order, obviously. The cardiovascular system, this is a perfect segue into the cardiovascular system because not only do we have the genes that affect your weight, and weight affects oftentimes the cardiovascular system, then we have a whole nother set of genes that directly affect the cardiovascular system. Again, I would start by looking at their symptom picture. Do they have hypertension? Do they have other symptoms, shortness of breath, even at rest? Chest tightness, pain, a family history of DVTs, a family history of heart attacks. Have they had a heart attack before? Are they having these symptoms of cardiovascular disease at a young age? These are all things that I would kind of look at. And normally that would trigger a doctor just alone sometimes to order these lab tests, and a lot of these lab tests are also routine lab work. But if you have a patient with a genetic disorder, you may find that you are going to be measuring these more often. Even if they come back normal the first time, you want to keep an eye on this person because you know they have that genetic risk factor. So,
can I just add one?
Sure, yeah.
And like a couple of things in there that are just really fascinating tools would be that ultrasound of the carotid is really just awesome information, and that's just not run of the mill these days. And then looking at the particle size, when we're looking at cholesterol, it's not just what are the levels, what are the particle sizes. We can really get a lot of information based on that, and as well as the adiponectin levels. So those, some of those are run of the mill tests, but some of them are more specific and not as commonly run, and can be incredibly beneficial in terms of helping your patient and understanding the risks associated with, cholesterol levels, for example.
I would suggest to add to the list always the oxidative LDL cholesterol.
Yeah, and
Also,
you know,
with
early
stress in
on,
general.
if you look at like a VAC test or a Boston Heart test, or I think it was Cyrex. They're no longer around, but those functional medicine cardiovascular panels often will include that. And then, you know, obviously with factor 2 and 5 prothrombin is not on there, so this isn't an exhaustive list. But I 100% agree. Yeah, looking at the oxidized LDL is going to be valuable as well.
Screening also, so these are kind of just like a brief overview of the most important ones, like homocysteine levels, lipid levels, triglycerides, cholesterol, and those things. But I do, you know, I would say like there are some that are really well paired, like 9p21 and the ultrasound of the carotid artery. Those are really, really good pairs. So you can kind of start to keep these in your head. You know, if somebody has a high blood pressure, so they have like maybe a defect in the AGT or the NOS, then just routine, you know, have them take a blood pressure cuff home and just keep it at their house and put it on themselves every now and then. Have you guys ever seen the ones that go on your wrist? You know, you could even just be advising your patients to do simple things like that. It doesn't have to be a blood draw or anything, so. Nutritional deficiencies. I talked a lot about this, but blood level testing, serum testing, you would want to look for some of the symptoms. Sometimes these people, you know, low vitamin B12 levels is really hard to see as a symptom. You're really going to pick that up on a blood test or looking at their red blood cells to see if they're too big, you know. This is going to be things that you would do more through lab testing, and maybe you would get more benefit from lab testing. And it's really helpful to know somebody might have a genetic weakness somewhere so that you can go straight to that lab test.
And I think, you know, I was talking earlier here with one of our docs about how B12 just isn't the most reliable in serum testing for retinol, not a reliable test. So intracellular tests can be really valuable. I don't know, I think I've found them to be beneficial in about 50% of the patients that I've used them on. So they're not always going to be the answer, and we have to look at a number of things, but knowing what the quantity of the nutrients is within the cell is going to be more valuable in a lot of cases. And then I'm a huge fan of organic acid testing. I just think it's a really comprehensive test that you can get nutrient deficiencies. You can learn about microbial, the microfloral balance in the gut, and that's going to affect, like we talked about before with food 2, B12 levels. And then beyond that, you know, you can look at whether there's yeast overgrowth. Yeah, of course.
About this intracellular testing, which laboratory that?
So SpectraCell Labs is the lab I've utilized. As far as I know, that might be the only.
And how do they do it?
I can't tell you exactly. I know that they use white blood cells, but I don't know the details. Excuse me.
Intracellular, yes. Intracellular?
Yeah, within the lymphocytes.
Yeah, intracellular.
Okay.
And what do they actually test?
They test a whole range of nutrients.
You can see our.
Yeah, and I mean, they're a handy lab. They've got a lot of good information, so you can definitely give you their
They
information.
give it the system, kind of what belongs to the cells, what not. It was from the 40s, 1940s, developed. There are certain
Intracellular
elements-
testing for nutrients
No.
was
Just
developed in the 40s?
what actually belongs to what levels of organization. Like what belongs to the plasma, what belongs to the. You're familiar with that system by any chance?
I'm not familiar with that system, sorry.
Yes.
But I'd love to chat with you about it afterwards. And then, let's see, I was gonna say one other thing about the previous slide, sorry. Stool testing, right? With nutritional deficiencies, if a kiddo has celiac and you're feeding them wheat, you can give them 1 million supplements and it doesn't matter. So whether you're going to be doing genetic testing, whether you're going to be doing stool testing, whether you're going to look at organic acids or zonulin, assessing gut function is incredibly important to optimizing nutrition status.
So treatment considerations would be based off a lot of these test results. Like like Dr. Angela was saying, you want to, check their gut microflora, and see if they're capable, if they're healthy, if they're capable of absorbing your supplements. And if not, you may have to, bypass while you're working on healing the gut. And these are treatment considerations too, and then maybe retest to see that your treatment protocol is working in lieu of, say, for instance, like an HLA test where you showed an increased risk of celiac or any, other autoimmune conditions that are on that list. So, aging-related genes.
Okay, so aging-related genes, we talked a lot about the different SNPs associated, and there's, the list is beyond what we have here, but you're always going to be considering these genetic polymorphisms and risk alleles associated with fracture risk and osteoporosis. If a patient has a family history of osteoporosis, the weight gain, adiposity, abdominal adiposity that could be related to either insulin regulation or hormone imbalances, mood swings and night sweats, hair loss, fatigue. These are all going to relate to the single nucleotide polymorphisms. And based on the results of that genetic testing, we can utilize other complementary tests. So some of these, they're going to be more run-of-the-mill conventional. I'm a fan of comprehensive thyroid testing, particularly for antibodies. We see a normal TSH and T4 all the time, and that doesn't mean that antibodies couldn't be 800, 1,000, and need to be addressed. And then, you could sort of delve into underlying viral infections or whatever else might be causing this antibody level increase. But also we can look at hormone testing. And you need to do whatever you're comfortable with. There's serum hormone testing, there's urine, there's salivary. My experience is with salivary hormone testing, so that's my preference. But you can get a good assessment of what's going on there, and then you can utilize the polymorphisms to determine the best path for your patient, right? Do we want to use bioidentical hormones, or do we want to make more of a choice in terms of botanical therapies to support hormone balance? When we're talking about mood disruption, looking at urine neurotransmitters can be effective. I actually utilize organic acids to assess neurotransmitters quite frequently. And then you can do testing for digestive function, pancreatic enzymes in order to assess the gastrointestinal function, right? Because we talked about earlier how the microbiome can affect the tryptophan, tyrosine, phenylalanine levels, and then that can affect the mood. So it's a holistic perspective. It's a comprehensive sort of picture when we do these tests in combination with one another. Okay, we already talked about this, but with CYP1A1, COMT, and MTHFR, you might want to do a salivary hormone test or a urine test, because when we're looking at potential risk for cancers, we want to know these 2-methoxyestrogen levels, the 2, 4, and 16 levels. That's all going to determine what's going on with your patient and how you can treat them and optimize their health and prevent illness, right? That's our goal. MTHFR, MAO, and COMT, all in combination, we know can affect neurotransmitters and hormones. So looking at those and the relationship between those risk alleles, we can get a sense of what we might anticipate for our patient, and then decide if we want to look at neurotransmitters more specifically, if we want to look at hormones more in depth. Treatment considerations. So when we're talking about a patient with a family history of osteoporosis, a sad diet, loads of soda, never exercising, you might want to do an early DEXA scan, or a DEXA scan more commonly. You might want to look at bioidentical hormones. When we're talking about the COMT and MAOA and MTHFR, mood support would be valuable. We can use prescriptions, we can use supplements, and then we can use herbs. And herbs are really nice too, because when we're considering working on supplementing the pathways involved in neurotransmitter production, herbs can often be a little bit more gentle and versatile in the way that they affect our patient as compared to just bypassing part of a biochemical process and pushing a pathway. So I'm a big fan of botanical medicine. And then diet, right? We can use our diet to balance our hormones. We can use our diet to balance our blood sugar, and these are really important factors. So methylation, I talked a little bit earlier about how this combination of risk alleles or single nucleotide polymorphisms can interact to cause all sorts of different problems in your patient base. Some of the basic things you might see are hypertension, headaches, mood swings, fatigue, rashes, anxiety. I mean, with methylation, really everything is affected, so you can see any combination of symptoms, infertility, and so on and so forth. So we already talked about these basic ones, but you can also look at your patient's red blood cells, zinc and magnesium, because these are really important cofactors. I'm not a huge fan of testing serum B6. That's something you could do, especially if your patient has neuropathy. If your patient has neuropathy and you see elevated B6, it's a pretty big thing to address. Whole blood histamine, I talked to you about earlier, but also looking at blood levels of ammonia, and then organic acid testing I love, so we can assess methylation based on some of the amino acids that are elevated and the metabolites associated with our urine. So those are all functional medicine tests that you can do, and there are multiple organic acid tests available. I think I just found out US Biotech has one. I had no idea. So methylation treatment considerations. These are all supplements. There are herbs too you can use, and diet is always going to be important. Like we talked about, lifestyle, elimination, sweating, exercise, these are really important things. But targeted supplements based on the interaction between single nucleotide polymorphisms is going to be really important. So whether you use 5-methylene tetrahydrofolate or folinic acid, whether you're going to use the methyl hydroxy or adenosylcobalamin, pyridoxine 5-phosphate versus just using pyridoxine HCl, magnesium in the multiple forms, zinc in the multiple forms, depending on the pathology or the presentation, you might want to use a different form of zinc, because I commonly will go to zinc picolinate, but sometimes zinc gluconate might be a better option. Or in male infertility, zinc, there's another form of zinc that Corey taught me about, but I can't remember what it is off the top of my head. Choline, I have to get back to you on this. I learned some interesting stuff on the break, so let's all be aware that choline is an important part of the biochemical pathways, but I might give you like a little up-to-date based on some new information I learned. And then all of the B vitamins, 1, 2, 3, and 5 are really important, and glutathione. And when we're talking about glutathione, you don't need to necessarily be doing an IV infusion of glutathione or like liposomal glutathione. Based on your patient, you could be giving them an acetylcysteine along with glycine and glutamine. It just depends on the patient. I'm going to give it back to Corey for Celia.
Yeah, so HLA testing, I know we just talked a lot about this, so it's probably a little bit of review, but if you have, there are the HLA markers, and we do a lot of CELAC testing, but there are other HLA markers that are associated with other autoimmune conditions. So there is actually quite a plethora of autoimmune conditions that you can test for to see if there's an increased risk. And again, you would want to be aware of the symptom picture of the patient presenting if they had a previous diagnosis. But big one is if they have a family history of this, because we know a lot of autoimmune conditions can run, and autoimmune disease in general can run in families. So you would want to look, so if there was testing, and this can be reversed, if you see, you know, a patient with an IgG to a specific condition, then you could go back and test to see if they have these markers, and then you might know to test their children. You know, you might know to test their family members, and that's a big deal. Especially since, you know, there's brothers and sisters out there that might not listen to your advice, but if you could hand them a test and say, look at this, I'm thinking of a specific brother in general, but that helps you to then, you know if there's an increased risk. So some treatment considerations, surveillance, diagnosis, that's a big one. With autoimmune conditions, I think everybody here can agree that diagnosing it is one of the biggest things. You can have a patient sit in front of you, which I have, with a million unrelated symptoms. And the first thing you're thinking is, this is a million unrelated symptoms. It must be autoimmune. Which one? You know, because they can just, when your immune system goes awry, it can really affect each person differently. So diagnosis and monitoring the disease and the inflammatory markers over time. This is helpful. The genetic test tells you the person has a risk factor. Then you use the functional testing to see if your treatment is working, if you're on the right path, if you've identified the target and you're moving in the correct direction. And establish the severity of the damage to the intestines. This is helpful too. Good to know where you start your treatment at. You know, are you looking at preventative, or are you looking at first calming down their symptom, their flare-up, like getting them out of that huge flare-up and then getting them back to the point where you can then start to reverse, you know, the damage. So there's really like assessing the person at where they're at in their disease condition is kind of how I would word it. And so to show you the list of other autoimmune conditions that have HLA markers that are associated with increased risk, just to see that there's a long list. And what I think is really interesting is some of these ones like type 1 diabetes. I really got to thinking, you know, because type 1 diabetes runs in my family and I have children. Well, you know, one of the scary things is when you don't catch that diagnosis in a child, because it comes off looking like, you know, the flu. They're sweaty, they're sick, they fall asleep and they never wake up. One of my friends just had a friend whose son died that way. They thought he had the flu, he went to bed and he never woke up. And I couldn't even imagine that. So, you know, these tests are fantastic just even in children. And I think honestly, if I were to use the HLA testing in any patient population, it would be any child that has a family history of these autoimmune conditions. Because if you can figure that out in a child, that they have an increased risk for a certain autoimmune condition, then you can start to shape your treatment plan that early. Think about what that would do for somebody's health. I mean, the implications for sure.
Right, and a buccal swab's like,
Yeah,
oh,
that's another thing. Yeah, doing lab testing on a child, enough said. I mean, really, like if you could just take a brush and swab it on their cheek, that's one thing. Doing an intestinal biopsy is another thing. Yeah, I can't even get my kid to eat certain foods, so.
Can any of us?
Yeah, I know. Right. So wrapping it up, how genetic testing and functional testing combine. Hopefully we kind of answered some of those questions about when we would use functional testing along with genetic testing.